All right, everyone. For the next hour, we're going to talk about what's new in RB research. And for those of you who don't know me, now by looking at this panel, you know me, because this is totally my jam. Of course, I put this together, but I kind of didn't realize how much this was my jam until I looked at it today. So I love RB, I love research and ways to make RB better, so obvious. Everyone up here has a connection with CHLA and or USC, including Brenda, right? And what you're going to talk about has a CHLA connection. And I love women in ocular oncology, and I didn't mean to put together an all-female panel, but I'm not mad about it. I'm not even a little mad about it. So we are each going to give 10-minute talks. And I guess I'll just quickly introduce you guys so you don't have to do it then. The first is Paula Belson. So Dr. Belson is an instructor of anesthesiology at USC and CHLA. She helps put my kiddos to sleep. Brenda Gallie, again, needs no introduction. She's known worldwide for all that she has done for RB. She is the medical director of World Eye Cancer Hope Canada and ran the service at Sick Kids Toronto for years and years. And Dr. Shaw is my colleague in medical oncology at CHLA. She's the director of the Cancer and Blood Disease Institute and Retinoblastoma Program of Children's Hospital LA and also directs the COG RB research. So, Dr. Belson. Questions at the end.
Okay. And what do I do to? Is it this?
I think so.
Okay.
Green buttons.
All right. Good afternoon, everybody. Thank you. Like Dr. Berry said, my name is Paula Belson, and I'm a nurse anesthetist at CHLA. I've been doing anesthesia over 20 years, but 17 years there, and began taking care of retinoblastoma patients with the late beloved Dr. Murphy, and now, of course, with the amazing Dr. Berry. So over the years, I've developed relationships with the families who I would care for on a regular basis. And so when I decided to go back to school to get my Ph.D., I was asked to develop a research question, something that I was interested in because, of course, I'd be spending a lot of time with it going forward, and something that currently couldn't be answered. And one day, I was speaking to one of the moms of one of my RB patients, and she was concerned that her 3-year-old son had already had over 40 general anesthetics, and she asked me what effect that might have on him when he grows older. Well, I didn't have the answer to give to her, and there you had my research interest. So when I started my topic for my dissertation, though, I realized that there was little information on long-term outcomes in retinoblastoma survivors in the United States. There's a lot of literature out there on treatment. There's a lot of literature on genetics in RB, but there was little on general health outcomes. So the literature review that I completed showed that most of the studies on quality of life in retinoblastoma survivors were from Europe and Asia, and they had varying results, which supported the need for further investigation. So for my dissertation study, I actually assessed health-related quality of life, which includes physical, mental, and social components, and social support and self-esteem as well, in adolescent and young adult survivors of RB from CHLA specifically. And I found that retinoblastoma survivors reported worse physical functioning and more depressive symptoms than healthy controls, but overall physical and mental health was comparable. Social support and self-esteem were also worse in the retinoblastoma survivors. But obviously none of these results have any association with exposure to general anesthesia, which was my true interest. So my current research is looking at cognition and exposure to general anesthesia in the retinoblastoma population. So questions about neurocognitive effects of general anesthesia in children began after research in the early 2000s showed that neurodevelopmental effects from anesthesia in animal models. And in 2016, the Food and Drug Administration issued a warning that said, and I will quote, "Repeated or lengthy use of general anesthetic and sedation drugs during surgeries or procedures in children younger than 3 years old may affect the development of children's brains." So as you can imagine, this sort of brought a concern with a lot of our patients and our families. But this data is primarily from animal studies. and subsequent results in humans has been mixed. Differentiating developmental or behavioral effects from anesthesia versus cognitive or intelligence effects is also being assessed. There's current clinical trials and clinical studies that are ongoing, including randomized controlled trials that are allocating children to different anesthetics, as well as looking at brain changes on MRI. More recent clinical trials have shown that exposure to one or two general anesthetics is not associated with neurodevelopmental outcomes, but there's very limited research on patients with multiple general anesthetic exposures. So I believe that retinoblastomas are a unique population. Retinoblastoma patients are a unique population to examine the effects of multiple general anesthetics, because as we all know, their exposure can be quite high. And while there can be the confounding variable of chemotherapy that they receive, the effect and chemotherapy's effects on the brain, other perioperative confounding factors such as inflammation and other stressors that are associated with getting surgery and the underlying condition that's necessitating that surgery are not significant typically, since most of the procedures are eye examinations. For example, a lot of the current literature on neurocognitive effects in anesthesia are in the congenital cardiac surgery population, and as you can imagine, due to their underlying cardiac disease, the fact that they are on cardiopulmonary bypass, these all serve as confounding factors to, in addition to the anesthesia that could be having neurodevelopmental effects. The reason a child may need multiple anesthetics in the first place may make them more prone to having neurocognitive issues, and isolating the effect of the anesthesia is difficult. So for my study, I had 98 retinoblastoma survivors who had previously received care at CHLA. The median number of general anesthetics that they received was 14, and the range was from 3 to 63 anesthetics. And the median duration of anesthesia exposure was 693 minutes, with a range of 226 to 3,603 minutes. The procedures that they had for general anesthesia were mostly eye examinations, radiological procedures including MRI and radiation therapy, and surgical procedures including enucleation and central line placement. So cognitive function, I used the Montreal Cognitive Assessment Tool to assess their cognitive function, which is a brief cognitive screening tool that has high specificity and sensitivity for detecting mild cognitive impairment. The MoCA, as it's called, assesses a broad range of cognitive domains that include executive function, short-term memory recall, attention, concentration and working memory, language abilities, and visuospatial skills, as well as orientation to time and place. The MoCA can also be adapted for the blind and visually impaired. And retinoblastoma survivors scored lower on the MoCA than healthy controls, who had, obviously, my healthy controls had very minimal anesthesia exposure. But the median scores for both groups were in the normal range. Retinoblastoma survivors scored lower than the healthy controls on the naming, attention, language, and abstraction subscales of the MoCA. And total anesthesia exposure was negatively associated with their total MoCA scores, as well as the language and abstraction subscales. However, when we looked at a subsect of the population of the anesthetic exposure to just under the age of 3, we did not see these associations. So we also looked at chemotherapy exposure, and we found that chemotherapy exposure was only weakly related, meaning it wasn't significantly significant to MoCA scores, and the only significance that we found was with the attention subscale. MoCA scores were also strongly related to socioeconomic status and the type of insurance that the patient had. But the MoCA scores were not related to visual acuity. So what does this all mean? Well, statistically speaking, the effects of early anesthesia exposure on MoCA scores are significant. We did find significance. But this effect actually has less impact on cognition than socioeconomic status. Remember also, this was a small single institution study with a statistically small sample size, albeit for a retinoblastoma sample, I feel like it's a larger sample size. And we only used a cognitive screener and not thorough like neurocognitive testing. But in the words of the late great Dr. Murphy, or paraphrasing for him, I might say, retinoblastoma survivors can still go to Harvard when they grow up if they want to. So in the future, it would be great to have some multi-institute studies. Different retinoblastoma centers do different anesthesia for these procedures, and that would make for interesting comparisons. Future studies could also include other neurodevelopmental outcomes rather than just cognition, which is what I screened for. Also, as I said, comparing different anesthetic techniques would be good. The results, also our results, surprisingly, well, maybe not surprisingly, but they showed that the effects of socioeconomic status on cognition were greater than the effects of anesthesia exposure. And previous studies have shown that socioeconomic status can have significant impact on cognition. So maybe more research should focus on health disparities and the socioeconomically disadvantaged. I just want to acknowledge the American Association of Nurse Anesthetists, which helped fund my research for this project, and then also, of course, thank you to Dr. Berry. Those are my references.
All right, so let's talk a little bit about liquid biopsy for retinoblastoma. So we are behind on screening, and we're behind on global awareness of leukocoria for retinoblastoma, but we're also behind on precision medicine. So what is precision medicine? Well, again, the oncologists in the room know this, but the ophthalmologists don't think about this very much. Ocular oncologists do, but ophthalmologists do not. So precision medicine means that you take specific information about the patient's tumor, and you use that specific information to dictate diagnosis or prognosis or treatment. And I can tell you with certainty, even though I've never treated most of you in the room, that no one had this because it's not done currently for retinoblastoma. And it's such a big push that both the National Cancer Institute as well as the Children's Oncology Group have had for a while something called the Pediatric Match Trial, which has a very simple goal of sequencing all of the various genetic variations. We talked about genetics, but all of the various genetic information that drives tumors in children to better match them with therapy. And so if this is such a push, and if we have tons of adult cancers that have this, and some pediatric cancers as well, why has no child with retinoblastoma ever been treated with precision medicine? And the reason is quite clear. It's because we do not biopsy retinoblastoma. So if you do not biopsy retinoblastoma and you don't get tumor tissue, then you don't get information about tumor tissue, then you can't use that information to do anything. Does that make sense? So and this is not something that was like fairy dust in the sky. This is the reason that we don't biopsy patients with retinoblastoma is that you can pull the tumor outside of the eye. And again, we talk about life being more important than eye. Pulling tumor outside of the eye can change the patient's prognosis for life. So we do not biopsy an eye with retinoblastoma. But if you can't biopsy, are there alternatives? And so the alternative that I'm going to talk to you about is a liquid biopsy, and that's a word that's thrown around even in the New York Times. And so what is a liquid biopsy? It means taking a biospecimen like blood or CSF or urine or sputum or aqueous from the eye and looking for either cellular or non-cellular components of the tumor. You're looking for information about the tumor without touching the tumor. And this was first described in oncology way back in the 1980s with clinical tests starting in the 2000s, all really for adults, and it's still a growing field. And so a tumor biopsy can give you a snapshot of a tiny little piece of the picture that is the tumor. Like you might not know what that is because it's just showing a piece. But a liquid biopsy, or the goal of liquid biopsy, is to gather really abundant information about the tumor to get the whole picture of what's going on. And in general, liquid biopsies are repeatable. So you see that this picture is changing. Longitudinally, you can follow these liquid biopsies to better understand what's happening over time. So about 7 years ago, if you don't like eye surgery, you can close your eyes. I might not be able to play this, but could you push play on there? So in 2017, at Children's Hospital Los Angeles, we were the first to describe using the aqueous humor, which is the clear fluid at the very front of the eye, as a liquid biopsy for RB. And this is the fluid that we are all looking at each other through. So if you touched your eye, you're gonna touch your cornea, and behind your cornea is the fluid of the eye, the aqueous fluid. And the reason that we were able to first access this fluid is because we started doing intravitreal injections of chemotherapy, and this allowed us for the first time to have access to this fluid. And so from a crazy idea, it is now well established and accepted that the aqueous is a source of cell-free tumor-derived DNA. That's a lot of words. What does that mean? It means information from the tumor, information that before you could only get from the tumor. And so I'm not gonna go over all of these, but just to show you that in the last 7 years, a pile of work has been done and various publications, not just from our center, but others, and we have gone beyond USC and CHLA to include multiple centers throughout the US, Canada, Europe, and the rest of the world. India is very close. In order to better study this fluid and to understand how we can help kids with retinoblastoma using this. And at the end of 2023, with years of data and information, we were able to move at CHLA from a research test to a clinical test. And what does that mean? A clinical test is a test that you do on patients in a validated clinical laboratory where you get the information in the clinical record. You can make decisions based on it. Where tests that you do in the research sphere, generally you often can't even share that information with patients, and you should not be making clinical decisions based on that. So this has been very exciting, especially, again, as I said, in liquid biopsy, all of pediatric oncology is lagging behind. So this was an exciting step forward. And so why does this matter in the next 5 minutes for you all in the room? Well, so we now have the ability to answer some really important questions, like, can we use the aqueous for molecular diagnosis? So I don't know if those of you in the room realize how unique it is to just look in the eye of a kid and make a decision that it's cancer, but that's unique. That is not done in really, I mean, I don't know, is there any other pediatric cancer that someone just looks and says this is what it is? It doesn't happen. It takes a certain kind of person who wants to do that, okay? So to have something that can give you a real diagnosis actually has value. And so, for example, the people in the room who treat retinoblastoma know that this is retinoblastoma. And because you can see the optic nerve, can I push on this? No, I guess not. Okay, so because you can see the optic nerve there and you can't see the optic nerve or any structures there, you can guess which eye will do better, and it's the eye that has less tumor. But what about these two eyes? Are they both retinoblastoma? And how are they gonna respond to treatment? I will tell you, one of these eyes is not retinoblastoma, but just at a glance, appears as if it is. And so, aside from not always knowing if it's retinoblastoma, we rely so much on vision in this field and on looking in and seeing the eye. But if you have hemorrhage or blood in the eye, or if you have a cataract in the eye that precludes the view, it actually can be hard to make the diagnosis of retinoblastoma. And in fact, in many places, sometimes an eye has to be removed because we just aren't sure. We say this is an eye that doesn't see, we can't entirely be sure it's not retinoblastoma, we have to take the eye out. But maybe now, instead of removing the eye, we have a test that can help tell us. And so what we found from an early evaluation of patients with diagnosis is that if you looked for information from the tumor in 2 different ways, and if you include tumors that were at least 3 millimeters, which is teensy tiny, you had about 95% ability to detect tumor DNA. You can also see that the markers, just look at the shapes here. So a normal non-cancer cell just has a straight line. So any areas that you see that are above or below the line are markers that are coming from tumor. And you can see in this child who was diagnosed with bilateral disease, the markers in each eye are different. And maybe those markers matter, and we can use that to guide prognosis for treatment. And one of the things that we have been able to identify in terms of prognosis is that for the first time ever, we were able to compare information from the aqueous for eyes that were saved and eyes that were not. And we found that this chromosome, this region of DNA, had too many copies in the eyes that did poorly. Those eyes tended to recur more often and fail treatment. Why? I don't know. We're still researching that, and I hope that we will figure that out together. And you see that right there. And again, 6p gain, this change in the chromosome, was associated with a 10 times risk of failing treatment in advanced eyes. So this is a survival curve there of those eyes. You can also watch the aqueous to monitor response to treatment. So again, anything above that blue line is from the tumor. Those are areas of abnormalities. And you can see at diagnosis versus the end of therapy where that line normalizes, that's showing you a test that this eye has done better and no longer has active disease at that time point. What we do now is we just look in the eye and make that decision, and you get pretty good at it, but to be fair, there's some haze in that eye, there's some seeds. It's hard to be ultimately 100% sure, and this test helps give us some information about that. Here's another example. You just look at the shapes of diagnosis in the right and left eye. Evaluating later for active disease, the right eye remains totally normal now, nice and flat, where the left eye still shows those alterations. Again, changes above the blue line are tumor derived, and you can see this eye is still active. We can also use the aqueous to detect active disease when we no longer can visualize the eye. And so this is an eye that had a late recurrence. We didn't entirely know if there was a recurrence or not because it was filled with blood. The ultrasound, the tumor measured exactly the same. There was some schmutz below the tumor. Is that tumor? Is that blood? I showed this to a lot of people. No one knew. So we took the aqueous, and you can see there was a lot of alterations there. And so we enucleated this eye, and there was massive choroidal invasion. And people talked about this the other day. Can we use the aqueous to detect retinoblastoma that's driven by MYC-N? That blue arrow there shows MYC-N amplification. People asked some questions after about MYC-N, like, oh, is that something I should see in my blood test? MYC-N is from tumor, and so you need a test that shows you information from tumor. In general, you're not going to pick that up in the blood. This would be something that the aqueous or a tumor test would pick up. These are known to be more aggressive eyes. And a negative test matters too. So this is a patient who was thought to have retinoblastoma, but in fact does not. And you can see here both of these profiles are normal. So finally, have we learned anything about safety? This is just from our center. We actually have this under review with double the number because we included some European centers. And so with the European centers, we had 1,200 paracentesis procedures to take the aqueous. We use a very small needle that's about the size of a human hair. You can see that comparison down there. And we looked at whether or not there were complications that were mild, meaning they go away on their own, moderate, meaning they have some lasting effect but no damage to the life or eye of the child, and severe, meaning you've blinded the child, you've caused risk to their life. And there was one mild complication, which is a little bit of blood in the eye that went away on its own. That actually held, that blood goes away in a couple of days, and that held with the increased number of 1,206 procedures. So that means the risk of a mild complication is 1 out of 1,000. Does that mean we'll never have a severe complication? No, but it means that overall, in a controlled center with controlled hands, this is a relatively safe procedure. And I am going to end with this last thing. Are there liquid biopsy applications outside the eye for children with RB? This is shared with permission of a family that I wish very much would be here. And again, I have permission to share this. So let's meet Mark. Mark was diagnosed with unilateral RB at 6 weeks of age, and he was enucleated. He had 6p gain. He also had a germline RB1 alteration. And while we were monitoring him, he developed a pineal cyst. That pineal cyst was monitored, didn't look like a pinealoblastoma, but it grew into a pinealoblastoma. Can liquid biopsy teach us anything about Mark's disease? We're not in the eye anymore. He does not have an eye with retinoblastoma. We're now in another part of the body. So here's the diagnosis of the pineal cyst. And here's the MRI later when he presented with vomiting and was diagnosed with a pinealoblastoma. His CSF, meaning the fluid from around the brain and around the spine, was tested at that time. There were no cells of the cancer in there, but our liquid biopsy test was positive for markers of DNA. He underwent surgery and high-dose chemotherapy and stem cell transplant. He did very well. And his MRI at the end of therapy showed that he had a regressed pinealoblastoma. He had no evidence of disease, and the thought was that he was cured. His CSF at that time showed no cells, and for all gold standards of disease, he was cured. But the liquid biopsy remained positive. His spine was also clear of disease. So what do you do when the gold standards don't jive with the new test? And the answer is nobody knows. None of us, no one in this room knows what to do when the gold standard and this new test don't jive. So we followed him. 2 months later, 4 months later, no evidence of disease, no cells in his CSF, but the liquid biopsy remained positive, ragingly positive. This isn't a little bit positive. You see all those alterations above the blue line. This is very positive, and you can see the 6P gain right there. And then he presented with acute somnolence and was diagnosed with a brain hemorrhage that required urgent evacuation and a recurrent pinealoblastoma. At that time, his spine now showed disease. He started on a palliative chemotherapy, but showed progressive disease and still progressive disease, and we lost Mark this summer. And everybody at CHLA loved this little kiddo, and we miss him so much. So is there a way that we can implement this technology for future babies like Mark? The answer is I don't entirely know, and no one knows. But I think whether it's the aqueous or the blood or the CSF, this is an opportunity for us to detect and diagnose these patients earlier, maybe look at cysts before they become pinealoblastomas, again, rare of rare of rare, and maybe get better therapies and implement them sooner when the CSF remains positive, the aqueous remains positive, or the blood is positive. I'm gonna end there, and I'm gonna turn over to some new, exciting treatment from Dr. Gallie. Thank you.
Jessie, that was a very powerful talk, and I have many questions for you. But first, I need to push the green button here. Oh, it's already there. Okay, I'm going to talk about the Chemoplaque for intraocular retinoblastoma. The work, we have no financial or, I wish we did have some finance to admit to, but no pharmaceutical company is interested in retinoblastoma yet. And all the beautiful agents, charities at the bottom have really helped us enormously to be able to accomplish this trial. The trial is running in 2 centers, sick kids, and then later was joined by Phoenix. I'll give more details, and if you really want the details, go to the clinicaltrials.gov website. So this all started when I had this patient, and I illustrate his whole care in the Depict Health timeline. All the yellow bars at the bottom are all the EUAs that this child had throughout the whole sequence shown here. And the blue lines that go right across from top to bottom are chemotherapy that was given that affects both eyes and the whole child. The 2 eyes are separated, and you can see with the little white space between them, and it also indicates the AJC cancer staging for this child with the tumor node metastasis and H1, which means he has an RB1 mutation that he carries, and that's the new, since 2017, the group led by Ashwin Malapatna, who established in this cancer staging thing the H1 to represent hereditary disease. But retinoblastoma is the lead. The only cancer that has H1 is retinoblastoma. Does that mean it's the only cancer with hereditary predisposition? No, it just means that society lags a lot behind following obvious ideas. So I had this patient in Toronto with all those previous treatments. You can see, I'll point to the left eye has a yellow triangle. And that means, and I'll point to yellow triangles later in my talk too, that means we enucleated the left eye. So he only had one eye left at the time when that picture is taken in the upper corner. And in the retinal drawings done since the 1960s, when the indirect ophthalmoscope was applied to retinal blastoma is always colored yellow. And blue is retinal detachment. So you can see already that there's a lot of yellow in the drawing. And the photographs, although they're interesting, they just illustrate what the drawing shows, because the drawing shows the whole eye. This is the standard of care for retinoblastoma worldwide since the 1960s, to do that drawing on that same piece of paper. So we're left with the choice in this one-eyed kid to remove his last eye or do external beam radiation, which has such lifelong dire consequences that it's become, those two things have meant you have failed to treat that eye if you use either of those. And that's become quite standard in the ophthalmology literature. So I was at a meeting, a World Congress in Barcelona, having a cup of coffee with the brilliant ocular oncologist Lynn Murphy. And Lynn said, that thing I've been working on for many, many years to be able to get chemotherapy into the eye without giving it to the whole child, finally has FDA approval to go in a human. It's been in rabbits, and now it can go in a human. And I said, I have the child. And I came home and spent the next week with Health Canada to get special access to be allowed to put a chemoplaque, which I named it that because it's obvious to ophthalmologists what that means, in the first patient in the world, which we did. And it's that little silicone thing there with the yellow topotecan drug in it. And we're putting crazy glue. We have to call it tissue adhesive because they sell a lot with coloring it blue for surgical, but it's really just crazy glue you could buy at the store. And you have to put it in a special spot, not on top of the yellow drug, otherwise the drug won't go into the eye. So you have to practice that using red wine. So we put this on his eye, and he had the usual kind of didn't like to eat kind of irritation that all of the children with a chemoplaque have had. And I'll talk a little bit more about that. It's like they're teething is how they behave. But otherwise, there was no particular problem. We left his in 70 days because it didn't seem to be causing any problem. We had nothing to go by. The middle drawing shows that all that yellow's disappeared, except around the blue, which is calcium, right near his optic nerve in one spot. And in the picture at the top there, you can see the white calcium and a little bit of tumor that still looked active. We kept treating that with many things, and it kept recurring. So we finally did a tylectomy, which is a procedure developed by my colleague John Chow in China to actually operate and do by a vitrectomy, take out the tumor. We took out his calcified recurring tumor, and now he's 4 years out with 20/40 vision in this eye, and you can see the drawing there shows no yellow at all. So that was the first patient in the world, and that convinced us that this was a thing to really further explore. So Health Canada said, well, you can't keep doing them under special access, you have to run a clinical trial. So we developed this clinical trial with the company, which is called 3T Ophthalmics. And the protocol is leaving the chemoplaque in for 42 days and taking it out at week 6. We picked that time because in the rabbits, at about 50 days, the drug was gone from the chemoplaques. So we wanted to be a little short of that, so that gave us the chance that each patient would have a similar dose over a time. And then we follow them officially toxicity for 9 weeks and then follow them for 3 years. There were 5 escalating doses from 0.6, 0.9, 1.2, all the way up to 1.8 by putting 2 chemoplaques on for the higher doses. And you can see the drawing there shows us putting it in on dry sclera and holding it for 3 minutes so the crazy glue sets. It's very easy to put it in just under the conjunctiva. I have to show this slide for the company. We have no conflicts of interest to declare. The company supplies the chemoplaques, but provides no funding at all to run the trial. both in Phoenix and in Sick Kids, we raised money from charities to run the trial. This is not a rich company because nobody wants to invest in therapy for retinoblastoma. So this shows a swimmer plot, which is, I'll try and describe this without a pointer, but you can see there's a line down the middle at week 0, and that's when the chemoplaque was put in. This is all the children that had chemoplaques, and you can see the doses of their chemoplaques are color-coded. And all the symbols earlier, before week 0, are all the treatments they had before they got to a chemoplaque. And after the chemoplaque was inserted, the line goes on till the length of follow-up. And so that's why it's a different length, because they're each followed for different times so far at this point in time. This is the current up-to-date time. And you can see some of them have already passed 3 years by looking at the bottom there. So the CR shows wherever there's no more treatment after the chemoplaque, then we've got a CR that automatically is put in this swimmer plot when there's no other event, anti-cancer treatment event has happened. And the DLT means dose-limiting toxicity. So that means there was some toxicity that by all the criteria for measuring toxicity meant you shouldn't go to a higher dose particularly. And one child at the bottom there is excluded because that child at 5 weeks, the father said, I'm too scared about my kid being on research, I have to pull him out. So we can't count that child at all. And you can see the child ended up with a whole lot of treatments. Maybe that was significant. So now, this is a phase 1 study with all those patients. And now we move on to a phase 2 study. And the dose we would prefer, the the treatment dose to go forward in the RP2D, the recommended phase 2 dose, would be the 0.9 dose. So I'll just show a few of the children to illustrate this. This is a little girl who should have been diagnosed because her family had H1 people in it earlier, but she wasn't diagnosed till she was already about 8 weeks old when we saw her because of leukocoria. And you can see on the right picture is her large tumor right beside the optic nerve. She got a chemoplaque, and this is the only image I have like this was a chemoplaque in the eye. I don't know quite how we got it, but there it is. And you can see the dotted green line on the bloody area in the middle picture. That's where the chemoplaque was, because the chemoplaque damages choroid and retina and makes a footprint scar wherever opposite where the chemoplaque is as drug goes directly through the sclera. And there was a little bit of active tumor still sitting there, but at the next visits, you can see the tumor is on the OCT in the blue box. The tumor has kind of disappeared, and this child, I just got a picture last weekend. She's now a beautiful little girl moving forward and still patching. And she patches easily with that eye, but her visual acuity would say, don't bother patching her because she's such poor, but that's only measure central vision. She uses all that normal retina around her calcium in running around and catching balls and doing everything. So it's important to not only focus on central vision. This is a child who has a DLT, you can see at the top, which is vitritis, scleritis, where the drug comes through, and vitritis are in almost all the children, which do respond to giving steroid. And you can see the yellow lines point to the tumor in the far right pictures. And as we move forward through all of this, here we are now out at 3.5 years. This is her only eye, and this is a child that was about to lose her eye, but runs around and chases pigeons on the sidewalk and can tell colors amazingly somehow. So it's really an eye worth saving. This is one of the ones who we took the tumor, who did the drug, the chemoplaque did not work, and the tumor was too large, and so it's taught us that that kind of large tumor for this topotecan chemoplaque is not a place to go. You have to be smaller and more softer tumor than this was. And so we all kept the eye till week 9 and then enucleated it, and that gave us the opportunity to see the scleritis under pathology. So here's the results at the moment. Those are, you see the total complete response rate is 58%, but the 0.9 dose has 75%. The 1.2 has 80% complete response rate, but has 2 dose-limiting toxicities. So that's why our preferred going forward dose is the 0.9 at the moment. And that's what we will publish when we publish this. So in looking at that 75% group, we noticed that one eye had been enucleated, giving an 8% enucleation rate. We then had the opportunity to go back to retrospective controls, because since about 2001, we've run a database with a timeline, the predecessor to what I just showed you from Depict Health, that showed every event that those children had had, every treatment event, and we had data on all those kids. So we could go back to all the features of those children in a similar time window to when the same kinds of treatments were available as those who got a chemoplaque. And that's the 2017 to 2022 retrospective controls. And we looked at just the ones that were treated with intra-arterial chemo. And you can see the best results in intra-arterial chemo are with 3 or 4 doses, with 13%, 17% compared to 75% for the chemoplaque. And then we looked at the enucleation rates and the enucleated eyes for our very small sample for the chemoplaque at dose 9 is 8%. But if we look at the 1.2 dose, it's also very small compared to the, and that means enucleation for any reason at all. So here is the timeline back again. And we realized that in this timeline, there's all these colored symbols, but all we could do is sort of count them, but we wanted to find a way to weigh the impact of those different treatments on the whole child, not just on outcome to be successful in cancer treatment. So we invented what we're calling the consequence score, and we call it CS is the short forms for consequence score. And off the top of our heads, we just put these numbers on. So just an EUA, we said we really don't know what's an EUA impact on a child, 1 EUA. And we don't have the data for that because we only counted the events of treatment. We didn't go back and count all the EUAs, but the data's all there in the old database that we're still using in sick kids. And so we put all these different numbers there. And tomorrow I get to talk in more detail about the methodology of clinical trials, including the novel use of complete response, meaning give no other treatment for cancer. So I'm going to invite all of you to participate in refining those consequence score values in a I hope somebody can help me run this in the middle of my talk tomorrow. You'll all will participate by putting your opinions in on what those numbers should be for everybody who has any interest or in retinoblastoma. So when we took the consequence scores and we looked at the total consequence score shown in red, added up for all the treatments in the year before the chemoplaque, and then compared to, in green, all the consequence scores of events after the chemoplaque, you can see that the chemoplaque certainly changed the pattern of care compared to pre-chemoplaque and post-chemoplaque. So the next thing we did was go back to our old database that I've been talking about and pull out eyes that match the treatment eyes. And here I show the 0.9 group at the bottom with the green chemoplaques, and all the ones at the top are retrospective matched controls, matched, and I'll talk more about this tomorrow, but matched very closely. But the main feature is the consequence scores, the similar between the pairs of matched patients and study patients and controls. Here's the Kaplan-Meier analysis for the 0.9 only, and it shows that the chemoplaque has a higher success to have no further cancer treatments needed for that eye. And the one drop down is quite a late recurrence, and that was where one of the tumors had, on fluorescein angiogram on a EUA, had a little bit of fluorescein dye showing up and a little sort of a hot spot in the middle of this lump, residual lump. And so that was lasered. So that gives that little drop down because a treatment was applied. We don't know if that was tumor, but on the next EUA it hasn't showed up, but we don't know. It doesn't matter. That's the definition of complete response. So we submitted this abstract a while ago, and at this time, the data we have now is a little more polished than that, and we were given the privilege of presenting this work in the COP meeting on Friday in a special plenary session. So retinoblastoma in COP is usually on the last day in the smallest room and nobody's there. So I don't think, I'm sorry to admit that I don't think this is because of the chemoplaque or because of retinoblastoma. It's because of the novel way to pull retrospective controls and run clinical trials for any cancer or many diseases following a very simple protocol with retrospective data coming out of an old database that was collected. Not for this purpose. It was collected because we wanted to care for the children and know who they were and know what they'd had already, but it seems to be a good use of that. And I think that's why they let us have this special presentation on Friday. Thank you.
So much exciting work being done in RV. I'm Rachna Shah, and I'm a pediatric oncologist at the Children's Hospital Los Angeles. And it is an absolute honor to be here today and share with you some updates from the Children's Oncology Group and talk about some of our future collaborations and things that we're thinking about through COG. All right, let's see. This green button does work. All right, so here's what I'm going to skim through over the course of the next 10-ish minutes. I'd like to start by a disclaimer saying that I also don't have any financial interest to disclose, no money. And I also would like to acknowledge that I'm presenting the work here of many people who inspire me and are my role models in this field, many of whom have been in this room today over the course of the day, over the course of this meeting. So not all of this is my work. And then I hope to wrap up with some of the unmet needs and think about the future considerations as well. So let's take a step back and even think about what is the Children's Oncology Group. This was launched in 2000 and is the world's largest organization that is dedicated to children, adolescent, and young adult clinical research. And we'll talk a little bit about what clinical research is. The COG unites more than 200 institutions across North America, Canada, Australia, New Zealand, and many other countries. And as we are recognizing more and more that in the study of rare diseases like retinoblastoma, global collaboration is the path forward, we are trying to find ways to break the boundaries and involve more countries that are low and low middle income. The Children's Oncology Group clinical research is funded by the National Cancer Institute and through the generosity of many philanthropists who also donate support. And the Children's Oncology Retinoblastoma Subcommittee, which is a part of the Rare Tumors Committee, has conducted 6 clinical trials till date, and I will try to briefly skim over some of those to give you a flavor of the work that has been done over the last 2 decades and more. So what is clinical research for those in the audience that might not be as familiar with it? It's simply the study of the health and illness in people. And there are 2 main types of clinical research. One is an observational study and another is a clinical trial. And I'll be focusing a lot on clinical trials today. You've heard these words thrown around as phase 1, phase 2. What does that even mean? So thinking about clinical trials, there are several different layers of them. The first and foremost is a pilot study where we're asking the question, is this study even feasible? Can we even study this treatment or this method of delivery in our children or adults? And a phase 1 is the next step, which is we're asking the question, is this safe to do, and at what dose or what delivery method is safe to approach this novel treatment or novel strategy that we're studying. A phase 2 clinical trial, we're asking the question about whether the treatment is effective in the disease that you're trying to study it in. And phases 3 and 4 clinical trials, we're trying to ask the question about whether these treatments are safe and effective in a larger group of people, and really trying to understand in a phase 4 trial, after we've achieved FDA approval for that treatment, now does it continue to be safe and effective in a larger group of people? So I hope this gives you a framework as we go through the next few slides. The first, one of the few studies that we had done was ARET 0331. This was first thought about in 2003. This is a phase 3 trial for group B retinoblastoma, so where the tumor is still inside the eye and is greater than 3 millimeters in size. And our main objective in this trial was to find out what is the 2-year event-free survival rate, or EFS, where we're trying to see how many children were we able to save from getting enucleation or surgical removal of the eye, or from getting radiation therapy, or from requiring other additional chemotherapies from what we had prescribed on this trial. And on this trial, our children received 6 cycles of chemotherapy with just carboplatin and vincristine without etoposide. And that was the main question we were asking, is can we omit etoposide in this group of children who may have great outcomes, and can we maintain those outcomes and reduce the side effects that they have from treatment? And these were the results of the trial. We were able to enroll 21 patients with 25 eyes, and the 2-year event-free survival rate was 65%, which was less than what we had expected for group B eyes at about 96%. And the 2-year overall survival rate was 100%, meaning that even though some of these children needed additional therapies, all of them survived with those additional therapies, whether that was removing the eye or getting radiation or needing additional chemotherapy. And our ability to save the eyes was about 85%. So the conclusion from this trial was that when we give local or focal therapies like laser, cryotherapy, and the addition of etoposide may actually improve our ability to prevent some of these events and improve our ability to save these group B eyes. Moving on to the next trial, this was ARET 0231. And this was initially thought about in 2002. This is also a phase 3 trial that was conducted, and it focused on children who had group C and group D retinoblastoma. So these are, again, retinoblastomas that are inside the eye, but have not just a retinal tumor, they also have vitreous or subretinal seeding, or both. And our primary objective for this trial was also to see how many of these children required additional therapies after 1 year, or what was their event-free survival rate at 1 year. And on this trial, our children received 6 cycles of what we consider standard intravenous or IV chemotherapy, which is carboplatin, etoposide, and vincristine. But they actually also received a novel delivery of therapy, which is subtenon carboplatin, to see if there's anything that we could do to augment our ability to control these seeds that are in the eye that can be problematic when it comes to our ability to save the eye. And these were the results. So we were able to enroll 4 children with group C eyes and 25 children with group D eyes. The 1-year event-free survival rate for group C was only 25%, and the 1-year event-free survival rate in group D eyes was 52%, which was actually more than what we had expected for group D eyes at 70%. However, this treatment came at a huge cost in terms of toxicity or side effects to our patients, meaning that even though this was effective or partially effective for our children with group D retinoblastoma in the eye, there were unacceptable toxicities, and that is why this treatment is not currently being pursued further. I'd also then have the honor of presenting ARET 2121 that Dr. Brennan and I lead through COG with many of our colleagues. This is an ongoing clinical trial that is a phase 2 study looking at group D retinoblastoma. So again, inside the eye, but with the main retinal tumors with vitreous and or subretinal seeding. The primary objective is feasibility, and our question really is, are we able to feasibly give intravitreal melphalan, which is a chemotherapy directly into the jelly-like substance in the eye, alongside with IV chemotherapy, which is carboplatin, etoposide, and vincristine. And there are two unique aspects about this trial. One is that even though these treatments are not novel, and we've been using this technology for many years, as you heard Dr. Berry share, this is the first study that is being done prospectively, meaning looking ahead in time as opposed to looking back in time, which is one unique aspect. And the second is that we have also incorporated liquid biopsy as a part of this study. So every time our children get an injection in the eye to receive chemotherapy, we collect that aqueous humor, and then we have the opportunity of studying this in our children within the context of a uniformly treated patient population. So the results are to come once we finish accruing. ARET 12B1 was a study we conducted in 2012, and this was a pilot study for group D retinoblastoma, and our primary objective was, again, feasibility, and all we were trying to find out is, can we safely give 3 cycles of intra-arterial chemotherapy to our children who have group D retinoblastoma? Now, this may seem like a question that we already know the answer to now, over 10 years later, because technology, our knowledge, and our expertise has advanced so much that IAC has become a part of our standard care at many institutions. But back in 2012, we didn't know a lot about this technology, and because we didn't know a lot about this technique, and we didn't have the right checks and balances in place in this study to prevent some of the side effects that our children unfortunately encountered on this study. So while we enrolled 14 patients on this study, the study closed early because of 4 feasibility failures, and we didn't have, as I mentioned, the right checks and balances at that time to prevent some of the side effects that occurred. ARET 0332 is a phase 3 trial that was conducted back in 2003, focusing on children who had group E retinoblastoma, where the tumor is still within the eye but occupies more than 50% of the globe. And our primary objective was to look at the 2-year event-free survival and the overall survival. And the treatment that our patients received on this trial was either surgical removal of the eye or surgical removal of the eye with chemotherapy after that if they had high-risk features by pathology, meaning that when the pathologist looked at these tumors under the microscope after they were removed, if there were certain predefined high-risk features, then our children received 6 cycles of carboplatin, etoposide, and vincristine on this trial. And this was really impactful and powerful because, again, this was prospective data validating a lot of the retrospective data that had already been published. This trial enrolled 321 children, and it showed that children who actually had high-risk features after enucleation, their 2-year event-free survival rate was 96% if they received adjuvant chemotherapy, compared to 99% without high-risk features who had just enucleation alone. The overall survival was great at 98%, and the median follow-up on this study was 4 years. So this study concluded that when you have these particular high-risk features in combination with each other, which is post-laminar optic nerve invasion with a massive choroidal invasion, these are associated with poor outcomes, and these children would benefit from having chemotherapy after surgical removal of their eye. The last study that I wanted to touch upon was ARET 0321, which is a phase 3 study that was also conducted in 2003. And this is the study that looked at children with retinoblastoma where the cancer had already spread outside the eye, meaning either they had disease microscopically or had spread to the lymph nodes or to other organs or even to the brain. And our, again, primary objective was event-free survival at the 1-year mark. And on this trial, children received very intensive multimodal therapy, so not just chemotherapy, but some of the children also received high-dose chemotherapy followed by their own stem cells to help them recover from the high-dose chemotherapy. And some children even received radiation therapy based on their response. And as intense as this treatment sounds, here were the results. We enrolled 57 patients on this trial, and for children who had disease just limited to microscopic disease or to lymph nodes or just outside the eye, they were curable. We still had hope for cure at 88% event-free survival. And the same thing with stage 4, if the cancer had spread to other organs, the event-free survival was still 83% with aggressive treatment. However, this was very sobering in terms of what our survival outcomes are for children where the cancer has spread to the brain. And again, to what Dr. Berry already shared, for children who have stage 4B disease, despite aggressive therapy, our event-free survival was quite poor at just 28%. So really a lot more work to be done and more therapies that we need to find. So I know that Jesse already touched on some of this, but here are really some of the unmet needs. We have some of our tools that help guide some of our management, but we need better tools in our arsenal that can really help us objectively define what is my child's risk of having this cancer be cured, or what is our chance of saving this eye, or what are the chances that when you say the treatment is done, we are really done. And is there a way for us to pick up relapse early like we do in leukemia and other cancers? Or is there a way for us to pick up treatment-related cancers or other types of cancers early? And also to study some of the unique aspects of how your own body processes chemotherapy and treatments and how you have side effects related to that. And so really, I think that one of the exciting tools in our arsenal for the future is liquid biopsy. And it's not just aqueous humor, cell-free DNA, but also looking at blood circulating tumor DNA and using this in combination to help objectively think about how we can help our patients and advance their cure, but also improve their quality of survivorship. So I'd like to leave you with a vision for the future, and I know that I have many, many steps before I can make this vision a reality, but we have to start somewhere. And here's my vision. You have a child who presents with retinoblastoma. We do a liquid biopsy at the time of diagnosis. The liquid biopsy tells us what is the child's risk factors and how aggressive is this disease? Do they have any high-risk factors that might make the disease behave more aggressively? For example, 6B gain or MECAN amplification. And I could use those risk factors to then say, I need to give you more aggressive therapies, or I can scale back on some therapies and really allow you to have a better quality of life. And then use these same tools in our arsenal to define when to stop therapy. So for example, if the tumor fraction in the aqueous humor or the blood liquid biopsies were negative, then I can be more confident that what Dr. Berry sees aligns with what the liquid biopsy is saying, and I can now stop therapy. Or if it doesn't align together, then I need to continue treatment until that becomes negative. What that allows us to do is to optimally treat our children and avoid this bucket where I know we are currently over-treating or under-treating a subset of patients because we don't have the ability to use these tools clinically. And so with that, I'd like to leave you with a lot of hope that we are we recognize the need for more work that needs to be done, and we are doing more work in this field, and we just need to do it fast enough. And must I say, I recognize how privileged I am in the practice of medicine in high-income countries where we have all of these tools, but I would like to dare to dream that this is something that we can even bring to low and low-middle-income countries in the future. We just have to start somewhere. And with that, I'd like to thank you all for being here, for sharing your experiences, for being vulnerable, and for being our greatest teachers, all of you, parents, families, patients, and really, again, for the honor to share the work that we're doing together. Thank you.
Thank you all. That was fantastic. So we technically have about 3 minutes for questions, although I just begged Marissa if we can have 5 more minutes. But let's maybe just see how it goes. We'll keep closing remarks short and save 5 minutes there. Go ahead, please.
Michael Sullivan from Melbourne. I remember the very first meeting in, I think it was 2002, where Anna Meadows got up and proposed these clinical trials, and was really challenging. And there were people in this room who were there about these trials. And the results have been fantastic. But my question is, and you heard my pitch earlier about the COG, what's the responsibility of the COG, which is funded by NIH, to conduct prospective clinical trials, to have trials that are translatable into other settings? And how do we achieve that? And that's our responsibility, isn't it? And we've had this discussion with Doug Hawkins, and he said the NIH only funds us to do these sorts of clinical trials that you present.
Yeah, no, thank you so much for your question, and I think you're really asking where we need to go, where we need to be is to have these studies be more geographically appropriate and adaptive. I couldn't agree more about that. And I think that we are moving in that step, in that direction. I think step 1 is recognizing that we're no longer just trying to solve the problem in America, we're trying to solve the problem globally. And I think with that is generating conversations. I know that we're miles away from really figuring out how to make these clinical trials available worldwide and really make them available clinically, but I think that we're heading in that right direction.
Thank you.
Thank you. Thank you so much, Andrea Reitzel from Denver, and RB Mom to Alexander. My question was about the liquid biopsy and baby Mark, and just brought the face to this liquid biopsy, but I know at the end of this, in this study, you saw all of the markers that said he had cancer, but you saw no cancer. Mm-hmm. In the future, does that change how you would treat him or treat another child with the liquid biopsy? Because if they see this, would we have done systemic chemo? Would we have, had we used that or as we go forward and use those tests, or as you go forward and use those tests, is that going to say, okay, we see it here, we need to do this?
Yeah.
Is that what's going to happen?
So Mark is, of course, an impactful story, and he was our patient, and we love him. He's with us now from heaven, and his family is kind enough to let us share his story. And of course, I share it because it's impactful, right? But I could have also shared a story that we started treatment and put him through 6 more months of chemotherapy, and ultimately what happened to him still happened, or that he passed from complications of therapy, right? The truth of the matter is that in research we say N of 1, that means it's one story, it's an impactful story, but we don't know the answer right now, and so we need to study this, and it's something that we're working with the team at CHLA to study these tumor markers in the CSF and to see whether or not they're impactful to predict recurrence, and whether or not early treatment would matter or have changed his trajectory at all. And when I sat with Mark's parents right before he passed, they asked me, would it have changed if we started treatment? And I gave them the honest answer, which is that nobody in the world knows. Mm-hmm. Thank you.
Hi, I'm Susan. I'm the social worker for retinoblastoma at CHOP. My question is primarily for Dr. Gallie. Before I was in retinoblastoma, I was in brain tumors, and our families who joined phase 1 trials were joining them as really last hope for maybe possible improvement of life or cure. With retinoblastoma, thank God at a place like Sick Kids, it's curable. So how did you talk to families about joining a phase 1 trial for a cancer that it wasn't sort of their last hope for survival?
It was pretty easy because the device, I have one in my backpack, you can see it, it's extremely simple. If it caused any toxicity to the eye or the whole patient while it was there, we could take it out in 5 minutes. And it had a very small dose, and in fact, I didn't mention it, but we've measured the dose, the amount of propotecan in blood, and there was only one child at the 24-hour after it had been put in, and he was the smallest child in the whole study. He had a trace level, so it was staying and going only into the eye. So all of those things just made it not a difficult thing to accept at all. And the only toxicities are the scleritis and the inflammation. There's no systemic toxicity. So it was a very simple phase 1 trial.
Well, with that, thank you for all you do to advance research in RB. Oh no, Dr. Gallie. Yeah, ask a question.
Paula, you commented on the EUA and all the measures and things that you reported. But I had recently a patient that I treated 25 years ago from a low-income country who kept coming back and forth for her extensive chemotherapy and everything. Ultimately, we didn't save either eye, so she is blind. She's now an actor in London, England, and she's produced a play about her whole life, and it's going to be showing at a festival in Scotland next August. But she talked with Helen Damaris and I recently, and about the most impactful thing about her EUAs was she didn't have good family support or community support throughout anything. She was bad because she was blind. She wasn't useful in her community. But then she came to EUAs and she said, that mask went on and I didn't know if I would wake up. So that huge psychological burden she's carried her whole life of the fear, but I had never heard anybody say that before. That's something we should try and study somehow.
Yeah, actually, that's a good point. When I was first deciding when I was talking about deciding all of it, like PTSD from anesthesia was something I thought about as well, about looking at, because I'd heard similar stories. You know, one family, the mom was telling me, one time she just leaned over her child in the plane to put the seatbelt on, and just kind of leaning over, the child, because it can be very, traumatic to children who don't want to go to sleep with a mask. They don't want to have it on, and we do have to, hold it. We do have to sort of hold them down. So it's definitely another area, I feel like, of the trauma. I've had, I did my research and talked to a lot of the adolescents, and one of the girls told me to this day she can't tolerate the smell of chocolate because we use the chocolate chapstick on her mask, and so just the smell of it, she can't eat it, she can't, there's a definite impact for sure.
There is. So is that an area that this group, the World Retinoblastoma, people with lived experience in retinoblastoma, could design a study to help us give anesthetics in a more respectful way to the child?
Yeah, I'd love to do a study.
You know what, Paula, in relation to what you were just saying, we have a question from our virtual audience. What is being done to limit anesthesia, and are we as a group promoting and utilizing ways to reduce anesthesia exposure in any way for better patient care and cost savings?
Great question. There is some newer research that's coming out. I've seen some articles being published about exposure and timing, and there was a recent one about, was it Abramson? I'm not sure, about looking at how much the EUAs added into anesthesia exposure. But as far as I know, I don't know if there's anything currently being looked at as like you said, a bigger trial of multiple institutions together. And like I said, I know that we all do anesthesia differently. I know the anesthesia we do at CHLA can be different than what they do at Memorial Sloan Kettering. I mean, it's, you know, it's an interesting topic. Sometimes you can't maybe necessarily get, you can't eliminate the anesthesia, but maybe there's a way we can give it that is, you know, better tolerated or better, less traumatic for the patients. So yeah, I mean, I think it's definitely goes hand in hand, in my opinion, right? You can't have all of these treatments, all of this done without a child who's anesthetized, because they won't cooperate and they won't tolerate it. So it's necessary, but there is, I believe, a lot that we can do to improve the process and to help that and to study that along the way as well.
Thank you all.